This morning, I'm very excited. I was told about a addictions doctor who was presenting incredibly insightful and important information on social media. Street Dr. Jill. And when people refer to her, it's Dr. Jill, Dr. Jill. People seem to know who Dr. Jill is. I had a look online and was just blown away by the amazing reels that she is presenting to the online community, which has grown substantially on Facebook and Instagram primarily. And I really encourage you to have a look. I would like to welcome to the podcast today, Dr. Jill Wiwcharuk. Thank you so much. She's an addictions doctor. Thank you so much for being here, Dr. Jill.
Thank you. Thanks for inviting me.
It's a real pleasure to have you here. And I have several questions for you related to your content and your online presence. But to start, I wanted to get an idea about your journey into medicine and tell us a bit why you chose medicine and how you ended up in addiction medicine specifically.
Well, I came to medicine as a second career. I got a Bachelor of Arts in Spanish and a Bachelor of Music in violin performance from the University of Victoria many years ago. And after that, I was living out of the country and working in different countries. And it was when I was living in India, working at a remote village north of Calcutta, when there was a very large earthquake that happened on the other side of India. And I really wanted to be able to go there and help. I was coming to the end of my time in Calcutta, and I reached out and they said, well, we need doctors and nurses. That's all we need. We don't need more people. And that's when I realized, that's a good idea. Maybe I'll be a doctor. Then I could really help people out when they need it most. And so with that in mind, I had another, I was really interested in studying languages. I had a few other languages I wanted to learn, countries to live in and work in before I came back to Canada and started medicine. And, from the beginning, I knew I wanted to do family medicine. And right from the beginning of my practice, I was working with people who were homeless. So having spent, starting working in the unhoused community right from the beginning of my practice, I never had a normal family practice, if you would. Like I always did outreach medicine or street medicine. And addictions were a large part of that. I mean, certainly not everyone who's homeless has addictions, but there are lots of addictions in the unhoused population. So I ended up getting a bit of some extra training in addiction medicine. I should also point out, I'm also an emergency physician, and I work in an emergency department as well.
Wow. So it sounds like by nature, you're very curious and have quite a bit of confidence because, you thought, I'll just be a doctor, and away you go and pursue it, achieve it, and execute it in one of the most, challenging areas, I would say, of medicine, simply because, there's still so much to learn and there's division in that space. So addiction medicine, when you went into that space, did you have any apprehension or was it just all in?
Well, again, it's only part of what I do. I'm much more than just an addiction physician. But it's an area, it's just having a little bit of extra expertise to be able to more fully treat people, because really so much of the population is affected by substance use and addictions that it's just good knowledge to have. So I don't see myself as just an addictions physician. That is just part of my clinical practice.
That actually leads me to my next question. As a physician yourself, I always felt, and of course, I have a biased view given the fact that I have lived experience with addiction, with substance use. And I've always felt that all doctors in Canada should have some form of addiction medicine training because they can be a point of contact for Canadians in the medical system that could be a life or death point of contact. And by that, I had explained to you in an email before, and I've told my listeners before that I had a walk-in clinic doctor tell me that I would die if I didn't do the 12 steps immediately. And I left very discouraged and just devastated and lacking in hope, because I had tried the 12 steps, and it just was not a program that worked for me. It saved many lives, but it's not for everyone. What do you think about the idea of all Canadian doctors having some form of addictions medicine training? Is it realistic?
Well, I think it's moving that way. Training is moving that way. I mean, especially in certain areas of medicine. There's some specialties and subspecialties that will never prioritize that. And there's good arguments for saying why everyone should, but the practicality is that there's just so much, and it's so broad. The scope that people have to learn and feel confident with is just so massively broad that it is a big ask that everyone have some training. Do I think in an ideal world that's what would happen? Absolutely. Because you're right. Physicians are in a unique place to touch people's lives at a time that might make all the difference one way or the other. And we never know, but when you're more informed and you can provide better care, you might touch that person's life in the right way. So ideally, yes, but practically speaking, I think it's more likely to be focused on certain specialties.
Yeah. Okay. No, fair enough. I think it's also having that compassion and empathy, as a GP or as an emergency room doctor or as any physician, that if perhaps you don't have the specialty and you recognize that need, that you bring in someone who does, or refer to someone who does, so the person can get the care, I suppose. As you started in the field, and you mentioned that you were working with a variety of patients, including homeless patients, what were some of the gaps in care related to, those living homeless, living without homes, and those living with substance use disorder that you recognized? And how did you feel when you were recognizing those gaps of care, if you saw any, when you began to practice?
Well, I mean, gaps in care, I guess I would see that as barriers to care. And I mean,
Okay.
There's no question that stigma is the biggest barrier to care in certainly with people who experience homelessness. Huge stigma. And then you add on, someone who's experiencing homelessness and has a substance use, an addiction of some sort. That's another layer of stigma, and then I always remind people that there's some, for example, there's other layers of stigma after that. Someone might be working in the sex trade. There's another layer of stigma. Someone might have spent time in jail and and anyone who's been incarcerated has another layer of stigma. People who are Indigenous, who are racialized, then there's other layers of stigma. Someone who's trans or in the queer community, another. So, sometimes I have people in my practice who might have belonged to 5 different groups that are all highly stigmatized. So then, they're walking through life, experiencing stigma, being judged, being treated poorly just about everywhere they go. And healthcare is no different. Walking into a hospital, walking into a clinic, maybe you're sleeping in a tent, maybe you don't have access to regular hygiene, you haven't had a shower in over a week, and you're hungry, and you're also maybe in withdrawal, and you're not at your best because you're feeling so sick because you're in withdrawal. And I mean, people feel a lot of stigma everywhere they go. And that would be the biggest barrier to care that I see in the population I work with. Many times my patients will simply refuse to go to the hospital. I've had patients just say to me, I would rather die at home than go to the hospital. I would rather die in my tent than go to the hospital, because I will not be treated that poorly again by anyone. I will not let that happen. And I have had patients that did indeed die without going to hospital.
I find that incredibly upsetting, as I'm sure you do. I've been in the ER for various reasons with other family members or friends, or for myself. And I have seen people there who would fall under multiple stigmatized spaces. And I have observed them. And it does seem in certain settings, and I certainly won't blanket the medical community. There are wonderful people working within it and within our hospitals. But at times they seem almost neglected in the hospital space, overlooked or left for long periods of time. And they seem to be in really, really poor condition. And I wonder about within the medical community, Dr. Jill, if this idea of really working as a community to rid the medical space of stigma has been a focus that you've seen at all as of late.
Well, I mean, I'm only part of one small cog in the wheel when someone comes into the ER, for example. I have because it's not just doctors and nurses that are treating people with stigma, right? Think of someone who's homeless going up and registering at the ER. What's one of the first questions? What's your address? What's your phone number? Instead of, do you have an address? Do you have a phone number? you know so and there's cleaning staff, there is radiation technicians, there are volunteers that are handing out food. There's just so many places and different people and different groups that are part of what goes into how someone feels when they go into the hospital. The medical part of it is only one small part of the interactions that they're having with people, not to mention people in the waiting room, right? And there's a lot of people in our waiting rooms in the ERs these days. They're crowded, there are long waits. It's a really hard time these days in healthcare in Canada. And those wait times are long. And, the general public also needs to learn more about stigma and treating people that are, treating everyone with respect and compassion.
I agree. Yeah, it applies also to the pharmacy space, the medical lab space. These are places where, people would go to get their methadone or their Suboxone, and perhaps the pharmacist is stigmatizing, or perhaps they're at a lab doing a urine test and they're receiving that. And I remember hearing the story of a young girl who refused to go get her Suboxone filled because she had to do a witness on her first dose, and the pharmacist was incredibly rude and just made her feel so much lesser than, and she ended up passing. And I myself am on Suboxone, and I just thought to myself, I felt that way, and it hurt to hear that. So also amazing pharmacists, and some of the ones that I've had as of late for myself and my family have been wonderful. So again, it's certainly not everyone, but certainly something. Shame and stigma is something that we really, really have to look at, as you've addressed. I wanted to. So data from the Center for Addiction and Mental Health tells us that about 21% of Canadians, that's 6 million people, will meet the criteria for addiction in their lifetime. You shared a reel on your @Street Dr. Jill, and it was titled, I believe it was Rage. Let me just pull it up here. Sadness and Rage. And it was related to stigmas, shame, and judgment. It talked about how a public emergency was declared in 2016, and then what you're seeing today as things have progressed. So all the great things that were put into place when that public emergency was declared, and then now how kind of things are changing and potentially changing in the future, not for the better. Dr. Jill, can you tell me about that sadness and rage reel, and really your feelings of sadness and rage, why you're feeling them, and where they're coming from?
Yeah, well, I mean, it just seems to me that the more toxic the supply becomes, the more deaths that we see actually the fewer resources that are available, and things that were put in place initially during the emergency are actually being rolled back on. We did have a safer supply program that is now being rolled back. There was support from the government for a compassion club in Vancouver, and that has been rolled back. In fact, those people are even being charged now and it's before the courts. There's less support for overdose prevention sites and supervised consumption sites. And I mean, that's all across Canada. But even in BC, which is really the birthplace of harm reduction in Canada, and that is really, really discouraging to see. My frustration comes with successive governments that have decided not to prioritize this, despite the fact that it is a public health emergency. It's the number, drug poisonings are the leading cause of death in people between the ages of from teenagers up to age 59, the leading cause of death of all these young people in our communities. Yet there's, and I mean, it's not like we don't know what needs to happen, because we do. There are lots of experts, there's lots of research. We know what needs to happen, and it's been presented to multiple governments over and over, and they decide to ignore it. Instead of leading, they are being led by people in the community that are scared, that don't understand, that might be lacking some compassion. And that's upsetting, because we elected leaders, and we didn't elect people just to follow the loud voice of the public. You need to have courage to look beyond 4 years of an election cycle in order to make some real change. And I'm seeing a lot of cowards in our government, and that's upsetting.
Yeah, no, I agree. I think it's very unfortunate that we started off on such a strong leadership path as a province, and it seems to have progressed. The safe supply that started, it kind of developed into a dialogue around diversion. And that was such a small part of the bigger picture. And the sensationalism of those news stories seemed to really take over the dialogue of what was happening. And it was upsetting to see, because we were on a good road and seemed to have diverted off. And we're talking about human beings here that could be you, myself, any other professional, whether they be a doctor, a lawyer, a stay-at-home mom or dad, someone in the trades. As you know, it doesn't discriminate. Addiction, I mean. So when you started Street Dr. Jill as a handle and started to put up these reels of information, and some of them are just very informative. Some of them, help clarify questions that people may have. What initially started you get to thinking about doing this online social media presence, and were you surprised at the growth and the positive response it's received? Because you have quite a number of followers.
Yeah, I mean, listen, you're looking to someone who didn't even have an Instagram account less than a year ago. Most of my time involving social media was telling my kids to get off of it. I work with a group called Doctors for Safer Drug Policy, and we had a communication strategist who came to speak to us. I mean, we've met with the health minister, we've written letters to we meet with politicians a lot. And she said, you're not going to get anywhere with that, because politicians are not listening to evidence. They're not listening to experts. Like I said, they are listening to public opinion. So if you really want to start making a difference, maybe it's time to start chipping away at public opinion. And that seems like a really big task. But I went home after that meeting and I spoke to my husband, who is a mental health professional with 25 years experience, and he's worked with this similar population that I work with. And I said to him, I couldn't do this on my own, but do you think we could do this together? Would you be up for this challenge? We can try it for 6 months and see how it goes and reevaluate. So, these reels that I make they're with my husband as he videos, and he is very, very helpful with content creation as well. He helps remind me that, Jill, don't speak like a doctor. You're not speaking to medical students and residents. You're speaking to general public. And so he's very, very helpful. And am I surprised, with the response? I mean, yeah, I am. I really had no idea what to expect. I just felt that as physicians, advocacy is an important part of our job. And when you work with such a marginalized population, that importance on the advocacy role of our job, just increases. And I have the privilege of these letters after my name and the privilege of doing work that I feel very passionate about. And I feel a bit of a responsibility to just try everything I could do to help improve the lives of my patients. So that's kind of where it came from. And as far as, how fast it's grown, I really don't have anything to compare to, because like I said, I was not really on social media to begin with, but I understand it's been fairly quick growth. And that's lovely. I think it speaks to the fact that it's a topical issue and people want to learn. And that's good.
Yeah, no, thank you for doing it and for taking that extra step. And it's refreshing to see a medical professional on social media sharing information that people desperately need to know. And some may be just uninformed on, and can hear from a doctor the realities of how withdrawal feels and those types of things. Harm reduction. You did a reel on that recently. I feel harm reduction can sometimes be misunderstood. Perhaps, it can be looked at as enabling drug use. Often people describe it as that, which we know not to be true. Can you share your thoughts? And I know this is a broad question, but just on what is harm reduction and how does it help save lives when it comes to our illicit, our toxic street supply here in BC?
Yeah, I mean, harm reduction, it's something that we all practice every day in our lives. You just don't even know it, right? Every time you buckle up your seatbelt or put a life jacket on your kid or use sunscreen, those are all ways of decreasing harms of activities that we're all going to do. And we decrease, I think of toddler proofing the house when you have a little one. My little one's going to climb. We know they're going to climb. So let's decrease the harms when they do climb. So it is actually something that everyone practices every day. They just don't really have necessarily a word for it. But as far as, being used in the context of drug use, the concept of harm reduction was started in the Netherlands in the 1980s by drug user groups when they developed the first needle exchange programs. And this spread quickly to other countries because it was phenomenally effective at decreasing the rates of HIV transmission. This was during the HIV/AIDS crisis. And so from there, it's come to include things like drug testing sites and supervised consumption sites and naloxone distribution and methadone and opioid replacement therapy like Suboxone and other types of therapy as well. So it's a recognition of the fact that people are going to use drugs because guess what? We've done it since the beginning of time and it's not going to stop. People use drugs. And how do we decrease those dangers, those harms that can come with it? And when people have addictions, they're compelled to use drugs and they might, even when they know that their next dose might kill them. But how do we decrease the harms until a time when they might be ready to cut back? Or maybe they won't be ready to cut back, but we're still decreasing harms. So, again, sometimes people think that harm reduction is just about needle exchange and just about overdose prevention sites or supervised consumption sites, but it's not. Like really, harm reduction, it is a whole philosophy and of caring for people that is just really pragmatic. It is common sense, and it's walking with someone down the journey, along the road with them, together with them, not lecturing to them, not telling them, it's providing evidence along the way. It's having compassion the whole way, of meeting them where they're at. And it's rooted in autonomy and dignity so that, it's not a doctor saying, Crack use is bad for you and you need to stop using or you're going to die. But it's, do you have some questions about crack use? How are you using the crack? If you're injecting, have you thought about smoking? What would be the difference if you did smoke? There are more harms with injecting. Do you have any questions about smoking? Is that something you might consider if do you have any interest in more information or maybe not? We're here when you're ready. You come back. In the meantime, here are some clean kits so that maybe you can stay safe. And for some reason that seems to be hard for a lot of people to, because there's, again, drug use is just rooted in so much stigma that they have a hard time sometimes wrapping their brain around that. And so I say to those folks, I say, hey, listen, compassion and, human rights and all that stuff aside, harm reduction saves millions of dollars. Millions of dollars. And I do mention this in one of my reels. There's a safe crack smoking kit to decrease the risk of hepatitis C. And that costs about $1 to the taxpayer. But when someone gets hep C, to treat them, it costs close to $60,000. And I mean, that's just one example. I could give you so many examples of where harm reduction saves taxpayers millions of dollars. In fact, if politicians did follow all the advice of these excellent experts and the research that's been done, there would be thousands of dollars, millions of dollars saved.
Yeah, so if the messaging is not going to affect them on the humanity and compassion side, perhaps it will affect on the financial and budget side. Benefits there. Yeah. No, it all seems very clear and logical, and the data has been presented. And like you say, it's become human lives have become political. And that is devastating to see in our province. I wanted to discuss a drug with you that I think very few people really know about or really understand. And that is, and I have trouble pronouncing it, benzos. So benzodiazepines. Am I saying that correctly?
Yes, you are.
So that would be things like Valium, Xanax, clonazepam, and drugs like that. They're both contaminating the street supply, causing significant problems with overdose and the effectiveness of naloxone. And they're also, commonly prescribed and highly addictive medicines that are really tricky because they work well for short-term problems, but are not meant for long-term use. Can be very, 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 addictive if used for long periods of time. Can you introduce my listeners to benzos and what people should know about this class of prescription medicines and how they're complicating the drug supply?
Well, I mean, yeah, so benzodiazepines work on the same part of the brain that alcohol works on, and the GABA receptors, and they tend to decrease anxiety, as you noted, similar to alcohol, actually, and they can be prescribed, and they should be when they are prescribed. It's mostly, like you said, for short-term periods of time, because there are other more effective medications for long-term use that are not addictive, and are much healthier to take long-term for anxiety. So benzos are helpful when you need them, for sure. I use them a lot in the ER departments. They're used often for sedation. But people can have a benzodiazepine use disorder where they are solely buying, some people call them Xanax bars, so little tablets of Xanax. Often they're not actually medicinal grade. They're made elsewhere, and they're not the same thing as Xanax, and much, much stronger and more dangerous. So sometimes people are just using that, but you're speaking about it in the contaminated supply of like street fentanyl, for example. So, what makes the fentanyl supply so toxic is the opiate itself is is extremely potent in the street fentanyl, in what people are buying on the street. And then it's also being cut with a whole bunch of toxins or contaminants. And one of these things in the last several years has been benzodiazepines or benzos, because what people want to do, they want to cut, a good cutting agent adds a little bit of weight so that, the person can get more money because people are buying based on weight. And also it kind of potentiates the effects of what the main drug is. So, fentanyl is a downer. It brings you, and with that, it decreases your respiratory rate, decreases your central nervous system. It can make you pass out. It sometimes decreases your respiratory rate so much that you stop breathing, and without naloxone, you might die. But benzodiazepines go in there, and they are also a downer. So then you have two of those together. And on top of that, like now it's gone past benzos, and there are veterinary tranquilizers in them too. I mean, tranquilizers that were meant to put out elephants and large animals, those are in the supply. So you have all these downer effects, these CNS, central nervous system depressants in the supply. Well, then someone, takes a puff, or takes a few puffs of down or what, that's the street name for fentanyl, street fentanyl. And then they go out. And if they stop breathing, people give them Narcan or naloxone. And as you noted, it doesn't always work because it's only working on the opiate part. And if there's other downers like veterinary tranquilizers or benzodiazepines in there that are in the supply, then that Narcan's not going to work. And I mean, on top of that, people are getting addicted to things that they didn't want to get addicted to, right? So yes, they have an opiate dependency, but oh my God, now they have a benzo dependency as well, not because they were seeking it out, but because it's in the toxic supply. And so then when people are coming into the emergency room, sometimes when they're in withdrawal, I mean, we're seeing constellations of symptoms that we never saw before because it's mixed, it's a mixed withdrawal syndrome that need medications all sorts of different medications when it used to be much, much more straightforward. So, it makes it harder for acute care in the emergency department. It makes it a lot harder for recovery too, because people are no longer just addicted to one substance. So it's awful. It's very sad. I should also point out that the benzodiazepines in the toxic drug supply are not the Xanax, that's not the Ativan or the Valium that we prescribe. They're actually they're types of benzos that were not meant for human consumption. They're very high potency benzos. Yeah.
Oh, I see. Okay. I didn't know that. One thing I heard, I was down speaking with Sarah Blythe of the Overdose Prevention Society, and people were yelling out, to me, offering me things as they do when you walk around in that area. And as you said, people have come to recognize that they are now addicted to both opiates and benzos because someone yelled out to me, we have benzo dope. I've never heard someone say that before, or benzo down. And I thought, wow, so it's come to the point that not only is it cut into the drug, but people realize it's there and they're seeking it because now they've been using it and have become dependent on it.
Yeah. I mean, transversely, you also have people that are don't want benzo dope and they say no. So it is, okay, great. So that's benzo dope. I'm going to avoid that, and that's not always going to work, but at least they would know that they wouldn't be seeking it out from that person.
Interesting. Okay, when it comes to, I just wanted to chat with you, Dr. Joe. I mean, I had to narrow my questions down because I have a limited amount of time with you and a lot of questions. So I only have a couple more, but I want to make the best of my time, and I do appreciate you taking the time to chat with me. I want to talk about withdrawal. So I think withdrawal is really important for people to understand, and it's because this idea of, you just need to stop. And the idea of the high and the euphoria that a substance user may be experiencing in their mind. I know from my experience, and I'm sure you've seen this in your patients, that there comes a point where it is avoiding withdrawal and feeling normal and level and not sick that is the primary goal of using substances. So the euphoria and the high are long gone. That was at the way at the beginning when we may have been self-medicating, but this is gone now. And withdrawal is absolutely unbearable. You describe it in detail in one of your reels. It's not so simple as just stopping, correct?
Exactly. Yeah. And again, different drug classes have different types of withdrawal symptoms. And I mean, for now, I think I'll speak to the opiate withdrawal symptoms. So opiate withdrawal, exactly. So you can start by, I mean, you laid it out well, many people start because they're treating some untreated mental health issues and they just need to escape. Other people have had a very painful, like maybe were in a motor vehicle accident and had really bad injuries and have chronic pain, and they're treating it for that reason, and that develops into an opiate addiction. But initially after that, those periods of euphoria, like part of addiction is getting tolerant. So you need higher and higher doses for the same effect. And you get to a period where when you don't have that, another part of addiction is having physical withdrawal symptoms. So, I mean, my patients explain opiate withdrawal. I mean, I see them. They're sweating. They're totally agitated. They can't sit still. They're like this. They feel like bugs are crawling under their skin. Vomiting, diarrhea, sometimes incontinence. It's so bad, and severe belly pain, and just this feeling like they are going to die. Like that nothing will ever be okay again. Like it is really awful. And some people, I mean, eventually with my patients who have severe addictions, all they are doing is trying to stay out of withdrawal. From the time they wake up, they're already starting to feel sweaty. They're starting to feel sick, and they need to find something to just get them back to normal. And again, not about getting high, get them back to normal. And this just continues throughout the day because they're using short-acting opiates, and then they get withdrawal, then they get normal, then they get withdrawal. And that is, I mean, with opiate use disorder, with an opiate addiction, what's nice is that we have medications that can treat that. So we have long-acting opiates that are controlled, that can be prescribed by someone, and you can get them at a pharmacy, and then that just keeps you feeling normal. So you're not having those ups and downs. You're just on a long-acting opiate medication that makes you feel normal. And then, sometimes over a long period of time, sometimes people start to go very slowly down on that. And so that, I mean, it's nice that we have such good treatment for opiate use disorder when people are ready. The same can't be said for crystal meth and stimulant use, crack cocaine, crystal meth, powder cocaine. We don't have fantastic replacement therapies like that, and people can go through, it's a different withdrawal syndrome that they have, but it can take a long time.
And the same for benzo withdrawal, which I understand is quite intensive.
Yes, and that's absolutely true. Benzo withdrawal are, benzos are what treat benzo withdrawal. They can be prescribed so that you get them, and they're safe because they're not made for elephants, and people can slowly go down on them. So that can be very helpful for benzodiazepine addictions. Yeah.
Okay. For those who are wanting to stop substance use, so we've talked about, and you've gone through some forms of harm reduction and tapering and different things. For those who would like to stop, whether it be, and we have to remember alcohol is also a drug, and that seems to be, in the public opinion, sometimes not considered a drug, but it is. Do you have any thoughts on methods of recovery that work especially well for your patients? Or is it simply each individual has their own journey of recovery, and it needs to be kind of tailored to their needs?
Yeah, well, I do have to note first, with alcohol use disorder, despite how many deaths there are due to the toxic drug supply, the toxic street supply, there are many, many, many more deaths due to alcohol in Canada. Alcohol kills many more people, but it tends to do it over a longer period of time. And people tend to be a little bit older when they die. But they are dying from alcohol, from their years of alcohol use. So, and yet it's one that people embrace. They celebrate alcohol. It is regulated. So that is very interesting, and something to keep in mind. But this, and I think that there's a bit of a dichotomy in treatment paradigms. I think one is basically abstinence based, and that would be kind of 12-step programs are the classic abstinence-based programs. And then the other is more of a harm reduction focus, where it's like, okay, we just let's do things at a stepwise at times that are right for you, and abstinence may eventually be the goal, but we get there through a different path. And certainly, I mean, with different substances are shown to be more effective in different pathways. Certainly with an opioid addiction, harm reduction has much, much better evidence than going cold turkey or abstinence. In fact, it's dangerous to go cold turkey with opiate uses. Or everyone is different. As you noted before, 12 steps works really well for some people, but it's not right for everyone. And we just need to recognize that everyone comes, into recovery. I mean, recovery is different for every person, and they all come to it from a different frame, with a different background, a different set of strengths and weaknesses. And everyone's path is slightly different. And we want to be providing care for people that is patient-centered, so that it revolves around what works best for them. And so you'll never hear me saying, this is the right way for you, because the person in front of me is going to know best what's right for them. I am just there to provide information and answer questions along the way.
Thank you. Thank you for that, Dr. Jill. I wanted to ask you something that's a question that, let's blue sky it. You're obviously very, very intelligent, have a variety of experiences in the medical field and a broad education within it. When it comes to drug policy and medical care, what do you think could help people who want to recover more? And what could we do? What could policymakers do to save and we are still in a public health emergency. People are still dying, hundreds of them a month in British Columbia alone. How can we start to save these lives? How to stop this health emergency? And provide the recovery options.
Yeah, it's as simple as listening to the experts, listening to the research, listening to the evidence, because it's all there. We need to demand that our politicians have the courage to look further than 4 years, have the courage to start implementing programs that are going to take some time before we see the true benefits, because it doesn't happen overnight. And but as communities, as populations that are being, communities that are being devastated by this, we need to demand better of our politicians. And instead of chasing votes, it's time to start listening to research and evidence. And so that's what I say. I mean, there's, within that, there's all sorts of different programs and things that need to be done, and they're all interconnected. But again, it's not something we don't know. We know what needs to happen. We need politicians to have the courage to enact it.
Okay. Thank you, Dr. Jill. To finish off, one final thing here is I wanted to just ask you briefly to speak on the Indigenous population. They are overrepresented when it comes to death by drugs, and also homelessness and using the toxic supply on the downtown east side. Your experience caring for Indigenous peoples, the overrepresentation there. Can you speak to that for a minute, the importance of that and really recognizing that in our efforts in reconciliation alone, not to mention public health?
Well, absolutely. That needs to be a focus. And again, Indigenous communities know what they need. They need there's lots of it being provided, culturally sensitive care. When I see my patients who are Indigenous, who are sleeping on the street on unceded territories of theirs, being swept away by bylaw, being told to go somewhere else on their unceded territories, and that same city council is starting each meeting with a territorial acknowledgement. Now, you tell me, that is such awful hypocrisy. And we know that absolutely this is part of reconciliation, is focusing. There are Indigenous harm reduction programs, and we need to be making sure that Indigenous people are part of the solutions in everything we do, obviously.
Part of the dialogue, yes, and a big part of the dialogue. Mm-hmm. Thank you so much. We have today, it's been an honor chatting with Dr. Jill Wiwcharuk. Did I say it correctly?
You got it.
Okay. She is a physician, an emergency room physician, an addictions doctor, and overall seems to be a doctor who has stepped it up with her advocacy via her online presence. You can follow her online on Instagram and on Facebook at Street Dr. Jill. I'll tag to that on the promotions and on the episode itself. Thank you so much, Dr. Jill, for taking the time. Thank you for what you do both online and spreading this information, and what you do in caring for your patients with true compassion. I really appreciate it.
Thanks for having me on, Rachel. Be kind and truly connect. You are listening to Rachel Thexton Connects.